Hello, everyone. This video is the start of schizophrenia, as in me teaching it. And what I wanted to do at the beginning was do a video that basically explained what schizophrenia is. It has got to be one of the most misunderstood disorders out there. A lot of people who are supposedly trained in schizophrenia get it confused with things like multiple personality disorder, for example, bipolar, although that's somewhat justifiable. But the point is that you do need to know the ins and outs of what schizophrenia actually is. So all this video is going to be me going through just need to check. No, that's not a good one. It's basically me going through what schizophrenia is using the DSM. So what I'm going to do is, what I've done is I have scanned in, let me just see if we can see that. I have scanned in, why are you not? Oh, yeah, hold on, sorry. There we go. I've just drawn everywhere. Whoopsies. This is going so well so far. I've scanned in the DSM, right? So the DSM, you will get to know, is a manual of all mental health disorders out there. It is a list of symptoms that the sufferer needs to have, as well as a lot of criteria. So I've got the schizophrenia one here. Apologise for the childlike handwriting, but I am going to go through these. Now, the first thing I'm going to go through is what the main symptoms of schizophrenia actually are. And there are 5, and they are all on the board. I'm sorry, I'm going to have to go out and clear that because that's really going to wind me up. Get this eraser. Oh, I'm having a mare here. I'm having a right mare. There we go. Childlike writing is over. There we go. Okay, so there we go. These are your 5 symptoms that you need to know. And as you can see up the top, it actually says that you need to suffer 2 or more of these, each present for a significant portion of time during a 1-month period, and you need to have done that for 6 months. So the first one is delusions, I should say at least one of these 2 must be either 1, 2, or 3. So the numbers just here. So the first one is delusions, right? A delusion is a faulty idea not based in reality. All of us have delusions, by the way, but not usually at such a deep level. Delusions include delusions of grandeur, where you think you are God and you genuinely think you're God, or Jesus Christ, or the Prophet Muhammad, for example. You genuinely believe that you are these godlike figures. Or that you have superpowers, that's quite a common one. Or you believe that a god or a supreme being is talking to you. That's a delusion. Hallucinations are when you have sensory input that has gone wrong. So you can have presumably 5 different types of hallucinations. You can have one of touch, for example. I think that's called tactile, although one's haptic as well. But anyway, you can have taste delusions. You can have auditory hallucinations. You can have visual delusions. Now, what people with schizophrenia tend to have is they tend to have auditory and sometimes visual hallucinations. So they have auditory hallucinations in the sense of they could hear somebody talking to them and they can't turn them off. And number 3 is disorganized speech. So frequent derailment and incoherence, babbling, for example. It's sometimes called a word salad or a vocab salad, where they're not making any sense whatsoever. There is not a coherent sense of semantics within their sentence structures, and they are talking all very weird. Weirder than that. Now, for you to have schizophrenia, at least one of your 2 symptoms has to be one of these. The problem is, if you just walk in with the next 2 symptoms, that can be indicative of other symptoms. So grossly disorganized or catatonic behavior. Type catatonic behavior schizophrenia into Google or YouTube and have a look at what that is. But it's when people basically, catatonic behavior is when people will remain in the same kind of shapes and molds and positions for a long period of time. And they're quite waxy. That's how it's always described. They're quite waxy in their positions. And the other one is negative symptoms. But negative symptoms basically looks like depression or maybe autism. So diminished emotional expression and avolition. Avolition is a key term you need to know here. Avolition is a lack of goal-oriented behavior. So, you can't be bothered to do anything. You can't be bothered to, you struggle to do anything. So, but again, that looks a little bit like depression, right? So you need two of those for a significant period, for a significant portion of time. I'm not going to read all of this out, by the way, just the main bits. For a significant portion of time, the level of functioning in one or more areas needs to be below what it was before the schizophrenia. So either your work needs to have suffered, your personal relationships need to have suffered, or your hygiene needs to have suffered. Now, that's quite contentious, because if you have hallucinations, delusions, disorganized speech, and you clearly have schizophrenia, but you are a resilient individual and you think, right, I don't know what's going on here, but I'm going to keep going, and you don't actually drop your level of hygiene, you don't drop your level of interpersonal relations, you will not get diagnosed with schizophrenia. It has to actually have affected you in your life. It needs to be, in the proper word here, it needs to be debilitating to your normal life. If it isn't, and if your life continues, you will not get diagnosed with schizophrenia, despite the fact you may actually have schizophrenia. So that's quite a contentious issue, really. Continuous signs of the disturbance have to persist for at least 6 months. So for you to actually get a formal diagnosis of schizophrenia, you need to have suffered it for at least 6 months. Now, full disclosure, I once suffered a lot of, when I was about 19, I wasn't very well at all. I was dealing with a lot of stress at the time, and it basically, I became very ill. I dealt with a lot of schizophrenic type symptoms, including things like intrusive thinking and things like that. It was horrible. I only had it for about 4 months. So I never got diagnosed with anything apart from a brief psychotic episode. But had it gone on for another 2 months, they may have said, okay, well, you're no longer having a brief psychotic episode. You're clearly actually suffering from schizophrenia. So what's a problem with this? And again, as always, it's worth noting down. For you, it's going to take you at least 6 months to get a formal diagnosis. That can be incredibly stressful, because diagnosing people can sometimes actually be a good thing, because it lets them know what they're fighting against. Also, you have the problem of treatment. If you don't get the right diagnosis, you're not going to get the right treatment. So that is a bit of an issue. That is a bit of an issue, the fact that you have to wait 6 months. Depression, you only have to wait 2 weeks before you are formally diagnosed with something. The problem as well is schizophrenia is not the only schizoid type disorder. It's the most common one. It's the most popular one, if you will. But let's have a look at the criteria D. Schizoaffective disorder and depressive or bipolar disorder with psychotic features have been ruled out either because there is no major depressive episodes that have occurred alongside it, a mood episode. Basically, you have to be able to distinguish between schizoaffective disorder, depression, and schizophrenia. And that's very difficult because the symptoms are actually quite similar. I'm not going to go through E because that's pretty much a given, but I do want to look here at F because this is quite important. If there is a history of autism, right? If the sufferer has had autism before, the additional diagnosis of schizophrenia is only made if prominent delusions or hallucinations exist. So if you've got schizophrenia, if you've had autism, you can only be diagnosed with schizophrenia if your symptoms are what we call positive symptoms. These two that I'm circling now, delusions and hallucinations, are known as positive symptoms because they are added to you, hence the positive. They're added to you, and they're things you didn't have before. Negative symptoms are things like hold on. Sorry, I have the feeling I'm going to get distracted quite a few times. So what we're saying, Negative symptoms are things like disorganized speech or diminished emotional expression. And these are things that you no longer have. They are things you used to have and you no longer have. So basically, if you have had autism or if you have autism, in order for you to be given the additional diagnosis of schizophrenia, it has to be delusions or hallucinations, because negative symptoms looks a lot like autism. Here's the problem. Are there some people with autism who have got schizophrenia, but it's the negative symptoms? But because the negative symptoms are very similar to autism, that schizophrenia goes undiagnosed and untreated? Absolutely. Absolutely there are. And these people will not be able to, according to this, these people will not be able to get treatment, which is pretty harsh. So it goes into it goes into a lot more detail. And there's a couple of things I do want to point out. I would recommend reading, I would 100% recommend reading this, particularly if you want to go into psychology, and certainly if you want to go into counseling or psychiatry or be a doctor, for example, you should definitely be reading this. And I'm not going to read all of this, but these are just associated features with schizophrenia. So individuals with schizophrenia may display inappropriate affect. That's emotions, basically. They may show inappropriate emotions. So laughing in the absence of something comedic, for example. They may have a dysphoric mood. Basically, a dysphoric mood is a low-level version of depression, but it's not cyclical, that you have moments of depression, then moments of contentedness, then moments of depression. Dysphoric mood is pretty constant. I had an ex-girlfriend who had it, and she was kind of not depressed, but she was low all the time. So dysphoric mood that can take the form of depression. They have disrupted sleep pattern, which is interesting. They have a lack of interest in eating food. These two are quite big, actually, and I've had more and more students with this. But again, just because you have depersonalization and derealization doesn't mean that you are particularly ill. And I always get them around the wrong way, so I do apologize if you do suffer this. But derealization is the concept where you feel like the items around you are not real. Like you can't touch them. All of a sudden you feel detached from reality. And people get this once, people get this often. So it's more common than people think, way more common than people think. Depersonalization is basically what we know as the outer body experience, when people feel like they come out their body and they can see themselves in real life. Now, you can have that and not have schizophrenia. In fact, if you have that, chances are you don't have schizophrenia, but you also do get it in schizophrenia as well. Anxiety and phobias are common. Cognitive deficits are common. Strong links. So look, it goes a lot deeper than those 5 basic symptoms. Abnormalities in sensory processing, as well as reductions in attention, so on and so forth. Some individuals with psychosis may lack insight or awareness of their disorder. So what this essentially means, every disorder, you either have insight or you don't have insight. And what that means is you are aware you are ill. With schizophrenia, generally speaking, people do lack, especially at the beginning, people do lack insight. They do not realize they're ill. If you have a phobia, you have great insight into that phobia. That's the term you should use, by the way. You have great insight into the phobia. If you have OCD, you have great insight. You know you are ill. Whereas with schizophrenia, you're wandering around thinking that you're God. You don't think I'm schizophrenic. You think, no, I am God. I am actually God. And it actually takes people to tell you that you are, in fact, not God. Hostility and aggression can be associated, but people actually, and this is worth noting down, people with schizophrenia are actually at more harm to themselves than other people. Aggression is more frequent with younger males. Fine. And actually, this is important right here. This is really important, actually. Non-adherence with treatment. If people do not adhere to their treatment, they can get quite aggressive. Why is that important? It's going to be quite useful to paramedics, for example, to know if what they're going into. So look, there's a lot more than what I'm actually showing you right now. neurological soft signs common in individuals with schizophrenia include impairments in motor coordination. So they might knock things over quite a lot, for example, because that seems to affect them. Sensory integration and motor sequence in a complex movements. Left-right confusion. So again, that communication between the left hemisphere and the right hemisphere isn't quite there with people with schizophrenia. So look, there's quite a lot. Now, prevalence, how common is this? People say 1%. That figure is thrown around. 1% is probably the higher limit. If we have a look at what the DSM says, and this is in America, by the way, which may be different to us, the lifetime prevalence of schizophrenia appears to be approximately 0.3 to 0.7, although, as it says there, there's reported variation. So in some countries, it could go up to 1.2%. In some countries, it could be as low as 0.3%. The sex ratio differs across samples and populations. So, for example, an emphasis on negative symptoms and longer duration is more common for males, whereas with females, that's not true. Now, this is also quite important, but again, I can't read all of it. But this is actually important for a few questions. Schizophrenia only tends to emerge typically between the late teens and mid-30s. It doesn't really appear before then. That's really, really important for certain exam questions, by the way. That's really important. It tends to be mid-20s for male, but later. So males do tend to get it more than females. The onset may be abrupt or gradual. Right, so you could literally wake up with schizophrenia one day and having never shown any symptoms before, or it may be a slow build-up. It does tend to be a slow build-up from what I remember reading. There you go. The majority of individuals manifest a slow and gradual development. Abrupt is quite rare. Half of these individuals complain of depression as well. And this is interesting. Earlier age at onset has traditionally been seen as a predictor of a worse prognosis. The earlier you get schizophrenia, the worse it can be. So if you get schizophrenia at, like, say, 14 years old, that's going to be that's going to be a really tough journey for you comparative to someone who gets it at 29, for example. The effect of I mean, look, I could talk about this all day. I find this so interesting. I don't know who's making all that sound outside. No, there are other things I want to do. I want to go through. Oh, Jesus, what's happened here? Oh, why are you doing this to me for? There we go. Now, look, there's a few things. Feel free to pause this at any point, by the way. Feel free to pause this. If you want to read the risk factors, I would recommend pausing them now. But there are culture-related diagnostic issues. So let's have a look. Culture factors must be considered. Ideas that appear this is really important for the next slide, but for the next video. Ideas that appear delusional in one culture, such as witchcraft, may be commonly held in another. That's really important. That's crucial, actually, for the next part. I'll say that again. Ideas in one culture, ideas that appear to be delusional in one culture may be commonly held in another. So this is the problem with the DSM. You can't come up with a universal list of delusions because in one culture it may be seen as delusional. Now, I actually know a witch. The true story. I actually genuinely know someone who classes themselves as a witch. She believes in the power of stones and puts all these things together. She's a fascinating woman. I've only met her briefly once, but she's fascinating. Now, I think, no, it's a bit left field, but certainly not a delusion. Do you know what I mean? Certainly not a delusion. Whereas in other cultures, there are still cultures that would deem that as incredibly delusional, and actually maybe they need to be thrown in a river or something. So culture is actually really, really important. There is a thing, here we go. In some culture, visual or auditory hallucinations with a religious content are a normal part of a religious experience and therefore would not be a delusion. Whereas if someone says, God is talking to me, we would say, right, you are deluded, basically. So you've got schizophrenia in one culture, but you don't have it in another culture. And that's a problem for the diagnosis of it. Gender-related ones, I'm going to go through this a bit more in lesson. But what I want to get to, suicide risk. I really want to go into this in too much detail, but approximately 5 to 6% of individuals with schizophrenia will actually die by suicide. Another 20% will attempt it. This is that idea about people with schizophrenia are generally at more risk to themselves than other people. The media in this country portray schizophrenics or people with schizophrenia as, dangerous, and they're not really. They're not. There's a few that are, of course, but they're not really. And there is an incident in the mid-90s that triggered this off. But let's have a look. I don't really care about that. A few more things. Comorbidity, right? This is what I also want to talk about because this is going to lead nicely into the next lesson. Rates of comorbidity. So what do we mean by comorbidity? What disorders are commonly suffered alongside schizophrenia? Substance abuse is really high in schizophrenia. So people suffer drug abuse as a result or because of or whatever, but they suffer alongside schizophrenia. Over half of individuals smoke. Comorbidity with anxiety disorders is increasingly recognized in schizophrenia. Rates of OCD and panic disorder are elevated. Life expectancy. So again, look, there's a lot of stuff. There's a lot of stuff here. But also, what's useful to know is the physical comorbidities, not the mental ones, like OCD, depression. Depression comes up a lot in schizophrenia, by the way. But if we have a look, life expectancy is reduced in individuals with schizophrenia because of the associated medical conditions. Weight gain, diabetes, metabolic syndrome, cardiovascular, and pulmonary disease are more common in schizophrenia because what's one of the first things that goes if you have schizophrenia? The ability to look after yourself. And so within the nursing field, I know they have a certain type of student who they typically have schizophrenia or delusional disorders. And these patients are called mental dental. Because generally speaking, if you stop looking after yourself, that one of the first things that goes is actually your teeth, and you're going to need surgery on those. So nurses, I know this because I've been with a few nurses over the years. Nurses call those mental dental. It's that weird, horrible black humor that nurses have. But they call them mental dental because they often have to do surgery in their teeth to pull it out because that's the first thing to go. If you stop looking after yourself because you are mentally ill, you're going to have physical comorbidities there as well. Now, I hope I have gone through schizophrenia in as much detail as you can. This is on the site, by the way. This is available for you to see. I would really recommend it because the next bullet point, or actually the bullet point we're on now, is actually the hardest bullet point in the whole 2 years of the spec. This is the easy part of the bullet point, admittedly. The next video is very, very difficult, but you need to have a really, really good understanding about schizophrenia. So as always, I hope that was useful. I would recommend reading the DSM pages on the site, on the Google site, on the psychology site for schizophrenia. You're certainly going to need it for the next lesson.